And I am glad you're here. And I know you're going to be glad you're here. Welcome to Frontiers of Brain Health, where we bring you the most exciting breakthroughs in brain science. A couple weeks ago, you learned about how important the locus coeruleus was to your attention, right? And then you learned about how acetylcholine can be increased through brain training, and PET studies show that. And today, you're going to learn how to take care of your brain from one of the world's experts. My name is Dr. Sandy Chapman. I'm the founder and chief director. I'm a professor here at the University of Texas at Dallas in the School of Behavioral and Brain Science. I love getting to see all of you so curious about your brain and what can be done. And Dr. Roseanne, there's actually probably 450 people online. So we not only have about 100 people here, but probably 500 people total who are so interested in this. If you don't know much about the Center for Brain Health, this is where you can start to learn to take action, as we talked about self-agency, so that your brain can be stronger every single day and that you will take charge of that and not just come here to be a sponge to soak things up, but share it with your community. What did you learn here? I see a lot of new people today. Bring your friends, have them join. We've got some exciting things coming in the coming months that you will not want to miss. We want every single person in Texas to be here, and really the nation and the world. Right, Dr. Roseanne? So I have the distinct pleasure of introducing Dr. Jonathan Roseanne. I think it was last spring we had a visitor here that connected me to you, and he said, "What's one thing I can do for you?" And I said, "You can connect me to Dr. Roseanne, because I want him to come. I want us to figure out how we can partner because of his amazing breakthroughs with his brain care score, the test that he's developed that could very much go alongside with the things that we were doing." But let me tell you a little bit about this amazing, compassionate humanitarian, Dr. Jonathan Roseanne. He holds the J.P. Kistler Endowed Chair in Neurology at Mass General Hospital. He's professor of neurology at Harvard. He's associate member of the Broad Institute. He's internationally known. He almost didn't make it to Dallas, I hate to tell you. He's supposed to be here at 3 o'clock yesterday. Remember our storms? He got here at 1:30 a.m., finally. After being waylaid to Houston, he stayed awake, and here he is today. So he's internationally. I hope he doesn't think we're international, but it was almost that long to get here, right? He's a scientist, but I think at his heart is really a clinician, to really help every single person to know what they can do to be better. He's an educator, he's a mentor, he's a visionary leader. That's the kind of person we like to collaborate with. Dr. Roseanne has created enduring multidisciplinary teams that are successfully tackling some of the most pressing challenges in brain disease. In 2007, he launched the International Stroke Genetics Consortium, bringing together for the world preeminent stroke investigators and created cerebrovascular disease knowledge portal to share data widely. After founding the Mass General Division of Neurocritical Care, I don't think he likes to stay doing the same thing for very long, but he stepped down and established the McCants Center for Brain Health with colleagues in neuroscience and psychiatry. Well, he can't have another Center for Brain Health and not work with us, don't you think? So Dr. Roseanne, you're on the line now to work with us. He's devoted his lives to caring for people. This coalition is sharing brain care network without walls around the world. His goal is to reduce, you'll love this, new cases of dementia, stroke, and depression by 10% in 10 years and 30% by mid-century. If we work together, I think we can do it faster and bigger, don't you? Please join me in welcoming Dr. Jonathan Roseanne.
Thank you, Dr. Chapman, for that lovely introduction. It is such an honor and a pleasure to be here. This really is where the brain health movement started, right here in Dallas. And I must tell you that when we were conceiving our really very small Center for Brain Health up in Boston, we looked to this center here as a model and recognized that the kind of multidisciplinary, community-embracing approach that has been pioneered here is really the model forward. Needless to say, I'm quite honored to be here. So what I'm going to talk about is my own journey and then some of the science that shaped it. Because I think our own personal journeys are important for each of us to recognize, to be able to articulate, but are also not that different from one another. And so recognizing the things we share in our personal journeys is a very helpful way for us to advance our scientific mission. So these are my disclosures. So I'm going to start with the power of science. And I'm going to go back to when I was 6 or 7 years old. You can see that I had long flowing blonde hair. It was the envy of all my mother's friends at the time. And next to me is Andrew, my best friend, who you can see we have identical bicycles because whatever Andrew had, I had to have. We were very close. And then one day, I was told by my parents that Andrew had died. And Andrew died of Reye's syndrome. It's the reason you don't give aspirin to kids. And his parents, his father was a chemistry professor. They didn't know what to do, so they established a lecture series. So this started when I was 8 or 9. And these are just some of the programs for the early lectures. But what was so striking to me is I would go to these lectures and understand zero. I'd be super intimidated. But it never was lost on me that science is the approach one can take to in response to grief and loss. Well, these lectures, which are now 50 years old, have gone on to stimulate a lot of science. So far, 5 of these lecturers have gone on to win Nobel Prizes. And in parallel, what's happened is a remarkable transformation in the care of children. So this is a timeline for Reye's syndrome. For those of you who are old enough, you'll remember one of the great things you could look forward to when you got sick was children's aspirin. It was flavored in these wonderful, I remember St. Joseph's aspirin for children, that orange. I wanted more. And Bear was, I think, bubble gum. But I preferred St. Joseph's, so that was what my parents stocked. And you know, from these ads, you can see that the message was, you want to take care of your sick child, you give them aspirin. We still use the term baby aspirin. Then in 1980, the very first epidemiological associations of aspirin use and Reye's syndrome were published. And then very quickly, there were warnings from government agencies and editorials in major journals about this association and to advise against the use of aspirin in the setting of childhood fevers. And by 1999, the New England Journal could write an editorial that declared that Reye's syndrome had been eliminated. And what's so striking here is that this was the example of a partnership of all stakeholders. There is no more invested stakeholder than the parent of a sick child. When our children are ill, we will go to all ends to find ways to help them. We're open to learning. And there was a trusted relationship across industry, government agencies, practitioners, and parents that led to the success of this effort. And so now, if you Google aspirin kids, this is what you get to this day. So Reye's syndrome remains in the public consciousness, even though it's largely been eliminated throughout the world. So fast forward, I'm a neurointensivist, and one of the lessons I learned is that you essentially recreate that experience of the parent with their sick child in the ICU. Because this is a time when patients and families are listening, when time is more free to use for doctors and nurses and therapists and clinicians. It's really where life's routine stops, which is a rare thing these days. You'll find families taking time off work to be with their loved ones at the bedside, even though there's nothing to do there but sit. And doctors are very focused on preventing further injury, recovering lost function, and then, and this is the sort of transformation of neurocritical care in the last 15 years, thinking about how you can use this opportunity to transform the lifelong trajectory of the patient and their family. You know, when you think about ICUs, I think about them as the Ritz-Carlton, because you have the highest ratio of providers to patients anywhere in the healthcare system, outside of maybe the operating rooms. You have a very high investment in technology. You have all the disciplines. We were able to build a very broad multidisciplinary team in our ICU, physiatrists, psychologists, social workers, anesthesiologists, and the focus is on patients and families. Why? In part because we have the time. We don't have another patient in the office who's got to come and be seen, you know, every 15 minutes. And our days can go on, can be longer if patients are sicker, or shorter if, for whatever reason, the patient list is not so acute. So just to give you an example of how to think about the ICU as an opportunity for prevention, I want to show you data that we published a couple of years ago where we studied intracerebral hemorrhage patients. So that's really the area, those are the diagnoses, the conditions where I've done most of my work is in stroke and hemorrhagic stroke. And we asked the question, for those 234 individuals who received longitudinal care in the Mass General system, what rates had they had for key risk factors for brain health deterioration, for cardiovascular disease assessed prior to coming in with their hemorrhage and afterwards? In other words, were they getting routine assessments before, after, or during? And what you can see here is that the overwhelming majority of individuals hadn't had an assessment of hyperlipidemia, sleep apnea, diabetes, or hearing impairment prior to their ICU admission. Then there's a big spike for assessment of hyperlipidemia, diabetes, a smaller spike for assessment of obstructive sleep apnea, and an almost undetectable spike with regard to assessing hearing impairment. So we have work to do in the ICU. But the point I want to draw your attention to is simply that this is where most of the risk factor assessment is being performed for these patients over basically the year-plus long period before and after their illness. So this is, again, the ICU as an opportunity to think about changing trajectory. So we've operationalized this through the use of an EPIC prompt so that clinicians can be prompted to order these tests for every patient who's admitted to our ICU and really begin to be prompted to think about what can we do to help them over the long term, way beyond the recovery from their injury. Now there's another aspect to an ICU admission, and that is the trauma of brain injury. And I'm not talking about physical trauma. So it turns out, and I began to notice this in my practice working with ICU survivors, that rates of depression, anxiety, and post-traumatic stress are remarkably high among survivors and their partners, their caregivers. And these are individuals who've never had a diagnosis like any of these prior. So we studied this, and what we found was that when you assessed people at baseline in the ICU, you found these strikingly high rates of anxiety, of depression, of post-traumatic stress, and you can see here PT stands for the patient, CG stands for the caregiver, and there's a correlation between them. But the key message here is that these symptoms develop early and they remain essentially unchanged over the next 6 months. So something about the acute event is associated with suddenly very high rates of this, and it persists. So we asked the question, why not work on an acute preventive intervention? Um, so we recruited a team of a psychologist and her team to the ICU who had expertise in developing dyadic interventions to treat both the patient and their partner, because we reasoned that that would be the most powerful way to intervene on the social unit. And so this is the preliminary, the early clinical trial results. We now have a phase 3 that is just concluding. We're looking forward to analyzing the data in the coming months. And what you can see here, I've just shown you the results for post-traumatic stress scores. You can see that for the solid line, those are the individuals who received our intervention, which is all educational, it's skills building, and it's mindfulness training. You can see there's a substantial drop in scores on measures of post-traumatic stress at 12 weeks compared to the control group. So we're quite optimistic, but this is what really got me started on the prevention pathway. So now I want to show you a little bit about the trajectories that we've been analyzing over the last 20 years of individuals who survive a hemorrhagic stroke. The CT scans on the left are of one patient who's had bleeding in the brain. The blood is the white in the middle of the brain. And the lines on the graph represent rates of what we call deterioration brain health. So this is cognitive decline, a new stroke, or incident depression. And what you can see for our Black and Hispanic survivors, this is in Boston, by 5 years, half of all survivors have developed one of these three events. This is the rate for white survivors. And then what we've done is we've tried to model, a little clumsily, what you would expect to see for individuals who have the blood vessel condition, which is called cerebral small vessel disease, that gives rise to the hemorrhage, but haven't had a hemorrhage, so it's much less severe. So you can see it's much less rapidly progressive. And then the dotted line, green line, is an estimate of the population level rates. So you can see it's a dramatic opportunity here. If you can arrest the progression of this blood vessel disease in these patients, we could presumably bring down rates of dementia, stroke, and depression dramatically. So that's where we began to think about, wow, this is a huge opportunity. And just to give you a sense of how easy this opportunity looks like it could be to seize, we've been studying blood pressure for decades now. And what you have here is the graph here is the average blood pressure over time in months. And we've stratified these groups of intracerebral hemorrhage survivors according to whether their average blood pressure was less than 120, 120 to 129, or greater than or equal to 130. And what you can see here, there's really a dramatic correlation between, or inverse correlation between your average blood pressure and your rate of recurrent hemorrhagic stroke. And if you look here at major adverse cardiovascular and cerebral vascular events, which is sort of a composite, the relationship is the same. So you might ask, why, if we know this, why are there so many individuals who have survived a hemorrhagic stroke whose blood pressure isn't less than 120 on average? Well, it turns out this is a phenomenon around the world. Blood pressure isn't well managed. So what you have here are data from our cohort where we asked the question, if you look at the average blood pressure over years on the x-axis, this is systolic and this is diastolic, and then correlate it with the blood pressure measure at 3 months, you see almost a nearly perfect correlation. What does that mean? It means that if the blood pressure is not controlled at 3 months in the life course of somebody who's had a stroke, it's unlikely to be controlled ever. So it's a huge opportunity. And we then modeled, well, what if we were to take the hypertension control rate at its current level, which we've estimated to be about 40% of all hemorrhagic stroke survivors, and just improved it to 50%. This is what we would predict would be a reduction in the number of just dementia and stroke cases as a result. So further improvement and so forth. So we have a great opportunity with blood pressure. The question we were asking was, okay, the doctors know this, the nurses know this, the patients presumably know this too. Why aren't we getting this done? And that's really what drove me to begin thinking about how we communicate between each other, how doctors communicate information to patients and families, and how patients and families use that information. And so that really led me to go into what I call now the field of health literacy, although that's not the best descriptor of it, but really understanding what goes on in a clinical encounter and how can we communicate the best science. Having devoted my career to pursuing the best science, I wanted to do more. So this is what I talk about now, the transition for me from being a clinician scientist to really being, I guess, a social entrepreneur and thinking about the opportunity around the world. So dementia, stroke, and depression are a global pandemic. These are just some of the ways to measure the impact. But if you compare the impact of COVID, what we just went through a couple years ago, to the impact of dementia, stroke, and depression on our lives around the world, there is no comparison. Orders of magnitude difference in terms of human suffering, economic cost, healthcare costs, but really human suffering. But because we've lived with this, I don't know, ever since life expectancy grew, it's almost as if it's part of the accepted background of the human condition. And we want to change that. So speaking of the human condition, when we've done surveys, what have we learned? We've learned that 75% of all US adults, and this has been replicated in countries around the world, 75% of us have had close personal experience with either dementia or stroke. If you add in depression, that figure goes to essentially 100%. So I think from today on, I would ask you to reconsider what dementia, stroke, and depression are. Instead of just being diseases that we so sorely want to prevent, diseases that frighten us, we also have to accept them as part of the human condition. And so once we do that, I think it's a way for us to engage together on this journey, because each of us will have our own story of dementia, stroke, and depression, either ourselves personally or someone close to us. So the solution to this pandemic is not going to be found in our healthcare systems or in our very successful pharmaceutical industry. There is a huge need for better drugs, and I'm really proud of the work that our team and others have done to contribute in whatever way to the remarkable transformation in human health that the pharmaceutical industry has catalyzed. But I think what we're having to face now is that the next frontier of human health comes back to us. It's in the decisions we make every day, in the way we relate to our friends and neighbors. It's really about our lived experience. It's not about a pill we take, or I should say, it's about, in some cases, our choosing to take a pill. So any solution to a pandemic has to engage. It has to be something that each of us feels is important. Each of us will do when nobody's looking and when we're all looking, but each of us does. And so what we've realized is, starting with communicating what you can do to prevent a disease, we have to ask ourselves, what's the way in? And what we learned early on was the way in was the question that patients and families would ask us. What can I do to take care of my brain so I don't end up like my mother, like my father? Because I don't want to put my children through what I'm seeing happen to my parent. It becomes the loss of dignity. That's the most painful future that we envision for ourselves. Not so much if we start to lose our memory, but really what that experience could be like for the people we love around us. So the opportunity is phenomenal. Estimates are that 75% or more of strokes can be prevented through modifiable risk factors. 45% of dementias, including Alzheimer's, and at least 35% of depression. And just so you know, depression, dementia, and stroke do go together biologically. Now, depression occurs at different points in life, and I'm not suggesting that the biology of what young people suffer is overlapping necessarily with the biology of what older people suffer when we suffer depression. But boy, if anyone who's taking care of an individual with Alzheimer's knows that depression often goes along with the loss of memory. It turns out that the biology of depression as we age, the biology of neurodegeneration, and the biology of cerebral vascular disease overlap substantially. Now, to your right, what you see is that there's been an enormous global recognition of the opportunity here. And there's been a lot of focus on how can you integrate brain health into primary care. So we started with that question. We quickly learned that primary care needs a lot of support if we're to put that burden there. So we've actually moved to direct to each of you, each of us, consumer. That's how we're going to tackle this pandemic. So over 5 years, we worked with patients and families and practitioners to figure out how to answer that question. What can I do to take care of my brain so I don't end up like my father, my mother, my sister? And what we did is we created a score where we identified 12 modifiable risk factors for dementia, stroke, and depression that were non-controversial. In other words, this score had to be the kind of thing that you could bring to your friends or bring to your neighbor, the doctor, and they would say, well, everybody knows this. We didn't want anyone ever to have the experience of somebody, an expert they knew and trusted, saying, well, that's not really proven. Because trust is so important here. So one of my favorite modifiable factors, meditation, had to be axed because the evidence is not 100% there. Now, please, don't get me wrong. Please do meditate. I think it works. And there are lots of ways to meditate. So I'm sure if for those of you in the audience who do meditate, you found ways that work for you. Don't stop. But know that what's on this list has a large volume of scientific data behind it that is from multiple groups around the world. Sometimes what I'll say is this figure represents billions of taxpayer investment in research over the last 30, 40 years around the world, but especially here in the US, and it represents thousands of scientific brains working this out, and then hundreds of thousands of patient volunteers who have generously donated their time to be part of these longitudinal research studies, all distilled into this simple figure. Well, it turns out this simple figure, this phrasing, score, care, brain care, has really been engaging. The New York Times, about a year ago, created a brain care score app. So if you go in the Times app and search for healthy brain habits, you'll get to the modified version that we worked on together in partnership with the Times. When it was released, within a week, there had been more than 1 million visits, 1 million people having filled out their brain care score. And that's just kept on going. But the bottom line is, this is the human condition. People want to know. You can go online to the Global Brain Care Coalition website, and you can download the brain care score, and you can compute it. I'm going to go through it very quickly because I'm sensitive to time, but this is the score. It's got 3 components. These are your physical components: blood pressure, blood sugar, cholesterol, and BMI. Lifestyle components are nutrition, alcohol, smoking, aerobic activities, and sleep. And then I think most important, because traditionally we haven't included these social components in our risk scores. You have stress management, social relationships, and meaning in life. So one of the most innovative aspects, in my experience, of this score is it gives people a choice of where to start. This is how you can make it your own. And that's part of what we want to use as the core of our approach to spread this around the world. And what's been so exciting to be here at this center is to see how you guys got to this long ago. Slightly different language, different background. I'm so reassured that we're on the right track when I come here and I meet with the leaders of the Center for Brain Health here. So because science keeps moving forward, the Brain Care Score will not be static. We are now in the process of developing 2.0, and this has been a lengthy, systematic engagement of over 40 international experts reviewing piles of data, coming up with the next version, which currently is under review. We're very cautious about releasing new versions. We want to make sure the scientific community validates it, but you'll be seeing that soon. And then just to give you a sense of the power of the Brain Care Score, this is some of the early studies. The UK Biobank was one of the great investments made by the government of the United Kingdom, where they started a study. It's about 20 years old. 400,000 people around the country were asked to volunteer to enroll in a study of health where they would fill out questionnaires on a regular basis, donate their biological specimens for analyses. And so we've been able to ask the question, what is the Brain Care Score when measured at enrollment in the UK Biobank? How does it correlate with subsequent risk of dementia, stroke, and depression? And so what you see here is the Brain Care Score of about 400,000 people has been, we've put them into different groups according to just quintiles, roughly a fifth, each equal. And then we've collapsed the three middle quintiles into the orange, and the green are those people who fell into the quintile with the best Brain Care Score, and the red with the lowest Brain Care Score. And this is time on the x-axis, and this is the rates at which these different groups developed depression, dementia, or stroke, and then this is the composite outcome. And what you can see here is there's a substantial difference with an average of 12.5 years between those people with a high Brain Care Score in green and those with the lowest in red in their rates of dementia, stroke, and depression. So what's really exciting is what we found in the UK Biobank study was the impact was greatest for those under the age of 50. Well, guess what? In this country, we have a kind of funky system, the way in which healthcare is paid for. Our employers pay for the majority of our healthcare, we and our employers, until we turn 65. And then the burden of our healthcare is shifted to the American taxpayer in the form of Medicaid. Medicare. So our employers don't really have an interest in investing in healthcare if the returns on that investment aren't going to be seen until after we turn 65. However, what these data show you is that investing in getting everybody's Brain Care Score up, people who are under 50 can really achieve dramatic outcomes long before retirement age, certainly before 65. So there's much more work to be done on this, and there's actually a lot of interesting work that's being done here at this center on understanding the economic implications for improving our brain health, but I think this is where we have to start looking. What can we do to help employers find ways to convert better health to financial savings? We can take this one step further, and this is where we've begun to go. Turns out that your Brain Care Score doesn't just protect you from brain disease, it's also heart disease, lung cancer, breast cancer, colorectal cancer. So the higher your Brain Care Score, the lower your risk of those chronic diseases. So it turns out that better brain care, in our parlance, is really associated with a life free or freer of chronic disease. So just a quick side detour into the state of primary care in the US. We have a problem. There's a shortage of clinicians. Each of us, I'm sure, has had an experience where we haven't had enough time with our primary care physician. We've probably gone through multiple primary care clinicians, and one of the real challenges with health quality is the lack of access for a substantial portion of the population to high-quality primary care. So that's not where we think the innovation is going to happen. The key to the brain care score, which is exactly the lesson, I don't want to say exactly because I don't want to be presumptuous, but I think it is really a core lesson of the Brain Health Index, is that the brain care score, like the Brain Health Index, gives an individual a way to understand and discover their own agency. And that's really what this is about. What we found in our work with patients and families is that brain health is really confusing. And I'm going to tell you a story that I think will change your view of brain health forever. I take care of patients who've recovered from strokes. Well, a stroke, as most of you know, is when a portion of the brain dies. So you have a conversation like this. Doctor, you told me that my wife had a stroke and therefore she lost a portion of her brain. Does that mean her brain will always be less healthy than mine? Now, the answer to that question has to be no, but it's really hard to ask individuals to understand that you can have a healthy brain that is just, with a portion of it that's died, be just as healthy as the neighboring brain that has no portion lost. But I'll take it even a step further. What do you tell a parent who says, well, my son has schizophrenia. I know that he will have schizophrenia forever. Does that mean his brain will never be healthy? Now, there are lots of ways that we can talk about brain health that can overcome these preconceptions, but it's a lot of work and it takes a lot of mental gymnastics. So what we've learned is we don't want to trigger those conversations. We want to trigger the conversation about anybody can take good care of their brain, no matter what the state of their brain. Our job is just to help them discover how to do that. So when we published the Brain Care Score, something remarkable happened. I got emails from hundreds of colleagues around the world, and many colleagues locally, asking about what they could do for themselves, their family members, but also, let's do something together. And that's how the Global Brain Care Coalition was formed. People, my generation, academics, frustrated that we have yet to actually have an impact with all of our glorious science, have an impact for people around the world who we really want to help. So the Global Brain Care Coalition is a learning healthcare community without walls. We meet regularly. We are always exchanging ideas. Our goal is to identify our core approaches, share them widely, and then help each of us and others partner with communities around the world so that we can actually bring brain care to communities and learn from communities how best to implement it for them. So it's really science, community health, and it's all the key stakeholders. Now, a couple of things that are at our core that we think are crucial. We have to always stick with the best science. Trust is so fundamental here. There is so much in the brain health space that is about making money. We all want to improve our brain health. So why not pay more? And one of the interesting challenges that I've found is that sometimes individuals are skeptical that getting better brain health doesn't cost a lot of money. So I got news for you. If all you do is keep your blood pressure controlled, you can save yourself a lot of money, and you don't have to buy anything because insurance will cover a lot of very, very effective drugs. We have to partner with champions. So, you know, I'm in probably one of the original champions. I mean, in the locale of one of the original champions, but we have to partner, and that's what Dr. Chapman mentioned in her introduction. We have to learn from behavioral science. There's so much out there about how individuals of all backgrounds learn how we develop habits, how we change. We must embrace that science. And then finally, we have to measure outcomes. So we've made a big investment in a data science platform to actually develop the kinds of COVID in the wastewater approaches to dementia, stroke, and depression. And it ain't easy. It's going to take a lot of creativity, but there's a lot of creativity out there. And this cannot happen without philanthropy. Philanthropy really is the way in which work like this can be supported. The federal government has been extraordinarily generous and catalytic in so many ways, but these kinds of approaches aren't traditionally supported through the National Institutes of Health. So this is a map of our current partners. The blue represents sites that are already using the Brain Care Score in very innovative ways within their community. The red are sites we hope will ultimately figure out ways to do that. These are some of our partner organizations, but just some. I do want to highlight a program we're launching, thanks to some very generous donors, is we're launching a community partners program where community health leaders, faith leaders, almost anybody can make a proposal to launch brain care in their community, and we will issue starter grants. Our goal is to launch cycles and cycles and cycles of community-based initiatives, learn from what works, what doesn't work, but ultimately this is the way we think we can channel this extraordinary momentum in the brain health space into communities in a way that builds more and more partnerships. So the first round, we hope we'll get the first RFPs out in the winter of 2026, and we hope to award our first grants in the spring of 2026. I have 2 more minutes, and I promise to be done by 12:45. There's a training program that has been launched in Europe that is global to develop a cadre of brain care scholars that I'm very excited about, because in part I was surprised to learn about it until I was called and asked to participate in the launch program in January. We have a learning community. This is how we convene. It's open to anybody, and this is where we meet now once monthly. We were doing it weekly. We've reconfigured it because we found that because of the different time zones, a lot of people weren't able to attend, but we record everything and we have a central learning hub. I'm going to keep going here. But this is where, right now, the community exists. We have worked very hard hiring a fabulous set of consultants to develop a welcoming and inclusive environment, one that is very hospitable to experimentation and to all disciplines. And the goal is really to help those of us who are moving more slowly learn the lessons from those who are moving more quickly, so we can in turn move more quickly. I talked about the infrastructure for monitoring outcomes. I just want to draw your attention to the dementiadatahub.org. One of the leaders of our data science platform from the National Opinion Research Council has developed this. These are the first county-specific estimates of dementia incidents that are derived from Medicare billing diagnoses. There are all sorts of reasons why this is not reliable, but it's the best we can do. I'm putting this up here to show you how much work we have to do to get from the state of the art, which is this, to something like COVID in the wastewater, where you can actually monitor the impact of what you're doing at the population level and tweak it if the COVID case counts or the dementia counts go up. So I invite you all, if you'd like to take the Brain Care Score, you just have to go to globalbraincare.org. It's such a pleasure to be here. I have got us done at 12:45 exactly, so there you go.
Way to go. That was so brilliant, and I think you can see why we need a partner to go faster. And I hate that Texas is in that dark blue, but it's because we have so many people, right? So many older people, but so much, learn so much, tremendous, if we work together faster. Okay, questions, come on. Bonnie and I will bring the Monitors to you.
Hi, I'm glad that I was able to attend this. I'm interested in solution for situations like this. And as you note on some of your deals about the community involvement in relationships, I'm doing some work on actually incarceration and criminal recidivism and addiction within a particular community, like a zip code. I practiced medicine in the inner city for like 28 years. And like what I'm doing is structuring a program to assess. We had a real-time case with this stroke. We had someone in our church that had a massive stroke, and I observed them. And so we become proactive in his management process. And I think that if we can design a program where from hospital to outpatient clinic and with the community, ideally the church, which is one of the main assembling areas within a particular zip code. I've been involved in it on all levels, from the clinic in the inner city to the church in the inner city. And I'm trying to write it up and structure it where it can implement the program to be as much proactive in the solution of situations, not only in stroke, but dementia, anxiety, criminal activity, reduction of incarceration, and reduction of addictions. So I will be contacting you.
Okay, I was going to say, do you have a card? Because I want to contact you. Let me just, please. I would love it. So, oh, yes, indeed. So I can't help but answer. Everything that you've just described, from the stroke to incarceration, these are all brain problems, right? So one of the things that we've learned with the Brain Care Score is it's like it's an instruction. It's your first course in your brain, because you can look at the Brain Care Score, understand that these are all steps you can take to take better care of this thing. And then what we've found is that it triggers curiosity about the brain. We all are curious about our brains. Most of us don't have the language that Dr. Chapman and her team have, neuroscientists, or that I have. But most of us know how our brain works, because we know that there are things we don't want to do, but we do them anyway, for example. That's a brain issue. So what I would really love to talk more about in subsequent. Yes?
So we've got another question here.
Yeah.
We've got another question.
Okay, we'll talk more. Yes, I'm with you, 100%, 100%.
Doctor, thank you
Yes.
so much for being here. May we acknowledge the trauma that you had in your young life and the legacy that that family has brought for all of us to have this increased education. We can never not consider those emotional issues in our life and what that can bring to our health and wellness later on. So first of all, I say that to you. I'm Paula Reed. I'm a speech pathologist, and back in the day when Dr. Chapman was teaching at North Texas, I've probably had my first stroke patient 50 years ago as a therapist, 50 years. So where we have come from, what we have tried to learn, my big issue now is what can we do to keep the next one from happening? Because I've had clients that have had 4 and 5. So we, build the sandcastle, the wave comes, knocks it over, therapist, right? So what can we do to not have that happen again? I love the fact that you were talking about Ray's syndrome going away and Bear and all of that, but I've just been recently at some seminars where we're talking about, I work with autism, and we're looking at the Tylenol issue for at least 9 years in my book. I've been talking about that, and we finally heard that in our government. And then I think the week later, I saw emerging from Bayer was taking over Tylenol corporately. And I just want to have awareness to what happened with Ray's. Let's look at our next medications. Thanks for bringing that up.
So I want to answer just one thing. What I think this speaks to is the importance of trust. And the way we build trust is we take information, but we don't control it. At the end of the day, it's about our own agency. And so, as you've learned with your patients, not all of us as patients are able to take advantage of the resources that someone like you can offer us. How can we change that, is my question at the end of the day. Yeah.
Very good. There's an online question.
This person writes, we know that sleep, nutrition, exercise, and blood pressure control, and a few other things, are the factors that determine brain health and overall health. In order to improve, I and others would need personalized advice in these areas. Do you see a future where advice can become individualized?
Absolutely. And I thank the questioner for that question, because that questioner has already taken the first step. They're curious. And once you're curious, then let your curiosity guide you. There are all sorts of technologies that we're talking about, how we can use AI to personalize advice. But at the end of the day, it's up to each of us to figure out what's going to work in our lives. And indeed, personalized prevention is far more promising, I think, right now than the precision medicine that I've been involved with as a genomicist for much of my career. Because each of us has the tools to figure out how we need to personalize our prevention.
So I have a question about your coalition. Are most of those MDs, or what is the expertise that makes up? As we begin to think about a course, a degree in brain health, what would that look like to you? And how many of your coalition people are not medical?
Oh, our coalition is very broad. So we have everybody from, members of, leaders in the ARP, to members of the faith community, to cognitive psychologists, to clinicians, to community leaders. I think if a course on brain health is a very ambitious course, and I'm very excited to hear that you're thinking about it, but it's going to be pretty multidisciplinary in my judgment.
Doctor, we've talked about this with some other experts. Given where you live and breathe, do you see a hope where the reimbursement community can really start turning the focus on the more efficient spend on prevention and promoting health rather than preventing disease or fixing the problem after it happens? You've got to align the incentives, and they're still screwed up. Is your coalition working on, because you got to get there?
Yes. The answer is absolutely. We have folks in the coalition who are thinking about this actively. My sense is the problem is, one, first of all, we have to be able to convey to very committed stakeholders like business owners in ways that are understandable to them and will make it comfortable for them to take the jump of investing some resources early on in this. So we have some work to do in that space. It's interesting, if you talk to entrepreneurs in this space, they're so good at figuring out how to work with the billing codes. That's the problem with our healthcare system right now, is that it is essentially, such a morass that so much creative energy from these incredibly talented innovators is being poured into how to work the system to jerry-rig something that is of value. So there's a lot of work to be done. I would come back to this. It's that 75% of us, in our experience, have been touched by dementia stroke, 100% by dementia stroke or depression. We start there, get people invested that way, and then that's how we start to figure out how can we get business owners to begin to think about an initial risk. So it's step by step.
There's Laura.
My question is, great to take a point-in-time score. Great to understand where you are at any point in time. How have you found keeping people really proactively following what they've learned, and what are some of the things that you've learned that helps people stick with it?
I know that I'm speaking amongst experts here who know far more about this than I do, but so I'll just talk about a few things. Number one is make it social. It turns out that, I haven't measured this, but there are many communities that have, that so many people want to help others, and they draw something from that. And so I find with patients, the key is not just sharing the brain care score, but exhorting them to share it with the people they care about, making it social. Second is help that initial encounter with it be about you decide where to start. So to be continued, but those would be my quick answers.
Very good. Here's one over here.
So this may be a continuation, a follow-up to her, or follow-on to the previous question. So my interest is in how you might, or how have you, the coalition, has the coalition addressed the issue of sort of making things culturally consonant? You talked about the data in terms of the scores for people of color. Has there been any effort, or can you talk about that? What is the effort to really try and address or develop things for that population, for that group of people?
Thank you for that question.
Right, yes.
We are obsessed with that because what we're learning is that prevention is all about the steps I take, you take, when you're home, when you're in a rush, when you're doing whatever you do, working. Each of us has a different set of lived experiences that condition what we can or want to do. We must understand that at each community level and ultimately at each individual level. So we have, on a scientific level, we've been studying lots of diverse populations to replicate those data that I showed you from the UK. And some of them are published, some of them will be published. But our approach is, this is a community engagement process. This is about a champion takes the brain care score, raises their hand, takes the brain care score into their community, and then co-develops a process with community members which may tailor the brain care score or change it, because our diets are fundamentally different, across Dallas, let alone across the country, across the world. So there's no way that one dietary set of advice is going to work. And that's just diet. Everything else is likely to be culturally conditioned. So what you're describing is the only way to success. So we are obsessed with that.
One last question.
Hello, Dr. Roseanne. Thank you very much for your talk. I actually work at the Ritz. I'm just being funny. I work at Baylor Scott & White in Irving. I'm an RN nurse. So we have a lot of patients in the ICU, but how do you see brain care fitting and looking at the continuum from being in the ICU, going to rehab, and then to home? But I, as an ICU nurse, stabilize the patient, but mostly I'm stabilizing the organs. So how do you see that as brain care health in my situation?
Thank you for the question. As you probably know, your patients and families have lots of questions for you. What if every one of those patients and families left with your having shared the brain care score with them? Think of it as driver's ed. And that's part of the Ritz-Carlton treatment in the ICU. You are given a tool to begin to manage your own health for the rest of your life. And I think the ICU is the perfect place to start, because that's generally where people are most concerned. So that's when we have access. So we have a ICU nurses program back home, because our nurses are, you get asked questions all the time, right? Now you can supply this, and it's simple. It's simple so that you can become an expert in it. Anybody can become an expert in it. So I hope that's compelling an answer.
I think that's very compelling. Please join me in thanking Dr. Jonathan Roseanne. So brilliant. So I hope every one of you will take the brain care test and also the Brain Health Index, and let's see how they work together to make a story. But brain health is our mission. It's our joint mission. We can change the world if every single person's brain was stronger year by year, don't you think? We're joining forces, right?
Absolutely.
Okay.
Yeah, we're like long-lost twins.
We are. This is my long-lost buddy that I'm so happy to find, and I'm glad that he didn't get discouraged from our flights, that he made it, with his international flight from Boston to Dallas. We look forward to seeing you at Frontiers Friday, December 5th. Dr. Stacey Warren will join us, rethinking mental health across the lifespan. So talking about depression, gaps and promise of mechanistic precision in treatment. And then get your calendars out. If all of you are really curious, we have a week-long activities. Laura Gordon is rocking it with speakers, with science, cutting edge. I now think we need Dr. Roseanne to join us. Brain Health Week 2026. Mark your calendar, especially February 26th. We're going to have the most breaking news from our Brain Health Project. How does your brain change? How can we get you to be enticed to be a good citizen scientist of your own brain and your community? Dr. Roseanne, thank you, thank you, thank you. Such an honor. Thank you, and thank you all for joining us.